Good afternoon. So, today we'll be discussing management of diabetes in this fourth semester seminar. And before moving on to management, we'll discuss certain salient points about classification and pathophysiology and its significance in terms of diabetes management. As we all know, the classification of diabetes has evolved from a previous classification which used terms like insulin-dependent diabetes and non-insulin dependent diabetes to terms like type 1 and type 2 diabetes, because it has been realized that not all persons with type 2 diabetes are non-insulin dependent, especially in their later stages. Persons with type 2 diabetes could require insulin, and similarly a small proportion of persons with type 1 diabetes in their initial years especially, they could have good insulin and C-peptide reserve and they may not require insulin. Other terminologies like malnutrition related diabetes mellitus have been dropped currently, and we have mainly we have type 1 diabetes, type 2 diabetes, pancreatic diabetes, which includes FCPD or fibrocalcific pancreatic diabetes, gestational diabetes, and other forms of diabetes. If we see pathophysiology of diabetes, you have two basic or principal defects, which include a beta cell defect culminating in insulin deficiency, and whatever insulin is present is not able to act properly at the level of various tissues. So insulin resistance, which results in decreased glucose uptake at the level muscles and adipose tissue, and it also amounts for increased hepatic glucose output, which causes hyperglycemia and results in a threshold. When it exceeds a threshold, we classify it as type 2 diabetes. However, it has lately been realized that besides these two principal defects, you could have defects at the level of other organ systems. For example, you could have defect at the level of beta cell, where there is impaired insulin secretion. Apart from that, at the level of alpha cells in pancreas, you could have increased glucagon secretion, which is counterproductive to insulin. Then you could have at the liver increased hepatic glucose production because of insulin deficiency or insulin resistance. You have decreased incretin effect at the level of GI system or gastrointestinal system. So incretins, we know, we will discuss this in further details. Incretins are hormones which are released by certain cells, for example L cells or K cells in intestine, which stimulate beta cells of pancreas to increase insulin secretion. Because of decreased insulin action or decreased levels of insulin, you have adipose tissue, which is another important player. You have increased lipolysis and reduced glucose uptake. And then at the level of kidneys, you have increased glucose reabsorption in persons with diabetes, which contributes to hyperglycemia. You have decreased glucose uptake at the level of muscle, and then you have neurotransmitter dysfunction. So there are various players in pathophysiology of diabetes, including pancreas, GI system, adipose tissue, kidneys, muscles, brain, and liver. So the pathophysiology of diabetes is varied, and you may need drugs which could require to be targeted at different levels. So management of type 2 diabetes extends beyond glucose control, because diabetes, it's not just hyperglycemia, it comes with a lot of metabolic abnormalities. So you need to, besides addressing hyperglycemia, you also need to address issues like obesity, dyslipidemia, various cardiovascular risk factors like hypertension, smoking. All of these need to be addressed. Goals for comprehensive control. So these goals, as we see, glycemic control, these are broad goals. However, these goals can vary from person to person depending on the duration of diabetes and various other factors which we shall discuss. For example, for most persons with diabetes, an HbA1c of less than 7% is an ideal control. However, this may vary. For example, in a person with various comorbidities, you may want to relax the glycemic targets. And pre-prandial capillary plasma glucose of between 90 to 130, peak post-prandial capillary glucose of less than 180, blood pressure of less than 130 by 80, low density lipoprotein or LDL cholesterol target of less than 100 should be followed. So what the question then arises is, has it been shown in various trials that good glucose control leads to reduction in microvascular complications or macrovascular complications? So yes, this has been shown in the pivotal study, which is United Kingdom prospective diabetes study, which showed that an HbA1c reduction of 1%, near 1%, leads to about 37% significant decline in microvascular complications. And it has also been shown that glucose control during initial years of diabetes leads to a legacy effect which protects person, which provides a long-term protection with microvascular complication. And as this can be seen from follow-up of UKPDS trial, we can see that even despite uh, even despite the fact that the two arms in UKPDS, which were initially separated by an HbA1c of 1%, after the trial was over, after the intervention was over, the HbA1cs tend to merge. But despite that, despite the fact that glycemic control tend to remain same after the intervention period, you could see that the difference in terms of microvascular disease, any diabetes related endpoint persisted, and difference in terms of myocardial infarction and all cause mortality in fact emerged significant after the in the follow up phase of the UKPDS trial. So you have a legacy effect where you could have initial good metabolic control contributes to reduction in the risk of future microvascular complication, and that is why it is said that you in your initial years of diabetes, your glycemic control should be more stringent. So as we have discussed, approach to management of hyperglycemia, it will differ. Whether you use a more stringent or less stringent goal, this will depend on various factors. For example, patient attitude, expected treatment efforts, whether patient is highly motivated, adherent, has good self-care capacity, you will try for a more stringent control. Risk associated with hypoglycemia, other adverse events for your treatment, if these are low, if you are using treatment which is associated with low risk of hypoglycemia, you will try to achieve a more stringent control. If you have very early disease or newly diagnosed diabetes, you try for a more stringent control. Similarly, persons with long life expectancy, you strive for a more stringent control as compared to those who are having shorter life expectancy or who are elderly. Presence of important comorbidities, if these are present, for example chronic kidney disease or presence of severe eye disease or presence of other comorbidities, you would consider lowering lowering your threshold, or you would want to be less stringent in glycemic control. If there are established vascular complications, you would be less stringent, and it also depends on whether resources or support system are available or not. Then your glycemic control targets may be modified. So coming on to management, management could be broadly classified into non-pharmacological and pharmacological. So it's important that non-pharmacological management is as important in diabetes as is pharmacological management. So non-pharmacological management, we define it as medical nutrition therapy, which consists of a structured diet plan, which should be ideally administered by a registered dietitian, and it should include not only quantity, quality, timings and spacing. All of these should be emphasized. So what we mean in terms of quantity, there should be a defined calorie amount that should be administered. The quality means quality of carbohydrates, protein or fat. Timings, so they could be in form of 3 major and 3 minor meals, in form of snacks, so it is important, and how these meals should be spaced. So all of these should be a part of a diet plan that should be administered to a person with diabetes at its first visit. And it is important that we empower patients with diabetes to have diabetes self-management education, that is, they take the responsibility of their own disease and they work with the physician towards their management of their disease. So dietary strategies used for prevention of diabetes, we have it has been shown that weight loss of more than 5% or more than 7% of initial weight is helpful in prevention of type 2 diabetes. Total fat less than 30% of energy consumed, of which saturated fat should be less than 10%. Frequent ingestion of food products which are rich in fiber. Another important term which I will like to introduce here is in terms of quality of carbohydrate. So you could have two substances which have equal quantity of carbohydrate, however the quality will depend upon glycemic index. This is something which defines the extent of rise in blood sugar in response to a food in comparison with response to an equivalent amount of glucose. For example, the glycemic index for glucose will be 100. So you, in terms, your reference substance here is glucose, and then you calculate glycemic index for each substance in reference to glucose. Substances with higher fiber, they will have a delayed absorption of carbohydrate, and so they will have a low glycemic index. And we want to prefer high fiber diet in persons with diabetes in order to lower the glycemic index and improve the quality of carbohydrate. And glycemic load is product of glycemic index with amount of carbohydrate in serving, and it tells you about the in total glycemic load of that particular meal. Dietary fiber, we know they are not digested by gut, and they are unavailable polysaccharides. So dietary guidelines in persons with diabetes could be small frequent meals, which would indicate a 3+3 meal or a 3 major and 3 minor meals. 3 major meals would include a breakfast, lunch and dinner, and 3 minor snacks would include a mid-day snack, which is between breakfast and lunch, a mid-evening snack, which is between lunch and dinner, and a bedtime snack, which is at the bedtime. It's also important to emphasize the quantity of carbohydrate, the quantity of calories in each meal, and the quality of carbohydrate, protein or fat that would be emphasized. Consume a variety of fruits, vegetables, grains, so all these items which are rich in fiber, low fat or non-fat dairy products, and also products with protein which is having high biological value. Obviously limitation of food which are high in saturated fat, trans fatty acids and cholesterol, and emphasize the diet rich in again fruit, vegetables and low fat dairy products. Again, it's very important that exercise, some amount of exercise is emphasized in each person with diabetes, because exercise improves glycemic control, and it has been shown to improve the glucose translocation, the disposal of glucose independent of GLUT transporters. It helps to achieve cardiovascular fitness. So it's important that 150 the recommendations are somewhere about 150 minutes per week of aerobic exercise, which should be at practice at least 5 days in a week. So you have 150 minutes per week of aerobic exercise distributed over at least 5 days in a week. Lipid risk stratification, we mainly target LDL cholesterol, and it should be emphasized that an LDL cholesterol target of less than 100 should be considered in persons with diabetes. For blood pressure control, it will differ, but in most persons with diabetes, you should target a blood pressure goal of less than 130/80. And then you have HbA1c or glycated hemoglobin target. So what is HbA1c? We know that glycation is a post-translational non-enzymatic linkage of glucose onto proteins through amino groups, and this is occurring at the beta tail of hemoglobin onto the valine residues. So proportion of hemoglobin which gets glycated will be a marker for prevailing blood glucose for the last 10 to 12 weeks, since lifespan of RBCs is around 120 days. So an HbA1c gives you an estimate of a long-term glycemic control over past 2 to 3 months, and so it will give an idea about your a long-term glycemic control. So targets for glycemic control, we have already discussed this. What should you look for in an oral anti-diabetic medication? When we come to pharmacological therapy, its efficacy, it should have efficacy over both fasting and postprandial blood glucose. Speed of action, like how quickly does it show effect. Barriers in terms of hypoglycemia, weight gain, cardiovascular risk, non-adherence, duration of action and durability. So these are barriers for use. So if a drug is having more hypoglycemia potential, it is one of the barrier. Weight gain, whether the drug causes weight gain, whether the drug is associated with improved CV risk, that becomes a favorable factor. Whether the drug is associated with a regimen which causes non-adherence, or which is associated with side effects which are likely to cause non-adherence, duration of action and durability, and safety in special population, for example renally impaired patients, elderly and cardiac patients. So we broadly we have following oral anti-diabetic agents which are used in persons with diabetes. These include sulfonylureas, which are insulin secretagogues, biguanides, which includes metformin, which is predominantly in insulin sensitizers. Then we have thiazolidinediones, for example pioglitazone, which are again predominant insulin sensitizers. Then you have alpha glucosidase inhibitors, which tend to delay the absorption of carbohydrate, which are a form of glucose lowering agents which act to reduce postprandial glucose. Then you have meglitinide analogs, which are again insulin secretagogues. We have DPP4 inhibitors, which act at the level of incretin pathway, which we shall discuss, and SGLT2 inhibitors, which act at the level of renal tubule to inhibit renal resorption of glucose. So if we see that omnious octet, or the pathophysiology of diabetes, so you have various drugs which are targeted at different limbs of these octet. So for example, you have drugs which are acting at the level of insulin sensitivity, you have drugs which are acting at the level of insulin secretion, you have drugs which are acting at the level of kidneys, drugs acting at the level of GI system, and various other targets. Coming on to oral secretagogues, we have sulfonylureas, which have an HbA1c reduction of about 1 to 1.5%. Again, it is important to remember that the HbA1c reduction with a particular agent will also depend on when it is introduced in the treatment protocol. For example, if it is introduced in a treatment naive patient, the magnitude of A1C reduction will be much higher as compared to when it is used as a second line therapy or a third line therapy or as a fourth line therapy in a failing patient, when the magnitude of A1C reduction will be lower. Then you have non-SUs, which can cause an A1C reduction of 1 to 1.5%. Metformin, biguanide, which is the most very commonly used drug, which could have A1C reduction of about 1.5%. Thiazolidinediones, pioglitazone, which work as a PPR or paroxysmal proliferator activator receptor agonist, and which tend to increase insulin sensitivity with A1C reduction of about 1%. Alpha glucosidase inhibitors, which decrease and delay intestinal carbohydrate absorption, and they have A1C reduction of 0.5 to 0.8%. GLP-1 analogs, which are analogs of GLP-1, which tends to which is an incretin which stimulates glucose-induced insulin secretion and also acts at the level of CNS to decrease appetite, and has been shown to reduce A1C about 0.8 to 1%. DPP-4 inhibitors work by prevention of degradation of endogenous GLP-1, thus stimulating glucose-induced insulin secretion, and they have been shown to reduce A1C by 0.5 to 0.8%. SGLT2 inhibitors inhibit glucose resorption in kidneys and causing glucoseuria. So they, in fact, they cause more glucose to be excreted through the renal route, and that is how they reduce your ambient glucose concentration, and they have been shown to have A1C reduction of up to 0.8%. In some studies are reaching up to 1% as well. So coming on to sulfonylureas, most commonly used sulfonylureas these days are second generation. The first generation sulfonylureas are not used these days, and these include drugs like glibenclamide, glipizide, gliclazide, and glimepiride. These are more potent compared to first generation agents, and they are more safer. Essentially, the efficacy amongst various drugs, these are almost equal efficacy. So there is no gross difference in efficacy between these agents. And how do these act? I will come in this diagram. This diagram shows normal insulin secretion. So you have this is the diagram of pancreatic beta cell, which shows that once glucose enters through GLUT2 channel, it enters inside the beta cell, it undergoes glycolysis. There is increase in ATP or increase in ATP-ADP ratio, which ATP in turn acts at the level of ATP sensitive potassium channels, inhibits the ATP sensitive potassium channels, and causes the release of causes calcium exocytosis and causes calcium endocytosis, depolarization of membrane, and release of insulin. So sulfonylureas, they act at the level of this potassium channel, but through the SUR1 subunit of this channel. So we have different sulfonylureas which are available. In these include glibenclamide, glipizide, gliclazide, and glimepiride. Important to note is that the duration of action varies amongst different sulfonylureas. Glimepiride is generally considered to be a long-acting sulfonylurea, so it can be given in once daily dosing. Another important thing is the activity of metabolites. Glibenclamide and glimepiride have been shown to have active metabolites as compared to glipizide and gliclazide, which have inactive metabolites. Compared to placebo, sulfonylureas cause HbA1c reduction by 1 to 2%. The A1C reduction remains similar with different SUs. There is no advantage in changing one over other for glycemic control. Microvascular risk reduction has definitely been shown. Regarding macrovascular risk reduction, there is no concrete randomized control trial based evidence, but there is evidence from long-term observational studies that these agents don't increase CV risk. Concerns with sulfonylurea, weight gain, yes, that can occur because they are known to stimulate insulin secretion. It's whether weight neutrality exists with glimepiride. This is a subject of controversy. Hypoglycemia is most likely to affect those who are elderly because their glucose reserve or their glucose compensatory mechanisms may also be at fault. Those with worsening renal function. So it is due to this fact that these agents should be used very carefully in persons with declining renal function. In fact, with GFR of less than 30 ml per minute, these agents should be avoided. Those with irregular meal schedules, for example, somebody takes a morning meal and then skips the lunch hour, the lunch, they are more likely to have hypoglycemia with use of sulfonylureas, because these agents cause glucose independent insulin secretion as compared to a person who is having a regular meal schedule. And hypoglycemia has been shown to be highest with glibenclamide, so it should specifically be avoided in these individuals who are at higher risk for hypoglycemia. The optimal dosing for sulfonylurea varies. As a general rule, glucose lowering effect tends to plateau after half maximal dose is reached. So, for example, for glimepiride, the maximal dose is 8 milligrams. So, you expect the glucose lowering effect to plateau after around 4 milligrams. And because they have hepatic metabolism and renal clearance, you should observe appropriate precautions in persons affected with hepatic or renal disease. Coming on to metformin, it mainly acts by decreasing hepatic gluconeogenesis, also prevents peripheral glucose utilization. It is not associated with any weight gain, rather it can cause modest weight loss, and there is no risk or minimal risk for hypoglycemia with metformin. Fenformin was an agent in this class which has been banned these days. Metformin, the A1C lowering efficacy is similar to sulfonylureas, varying from about 1 to 2%, and it has been shown to reduce both microvascular and macrovascular complications. Coming on to contraindications for metformin, earlier contraindications used to be creatinine of more than or equal to 1.5 in men and more than or equal to 1.4 in women. However, these have now been replaced by GFR based contraindication, which we shall discuss. In any person with cardiac or respiratory insufficiency or any hypoxic condition or severe infection or alcohol abuse, metformin use should be avoided because these conditions put person at increased risk for lactic acidosis. So you should avoid metformin in such conditions. And metformin can be temporarily withheld during surgery or prior to surgery and acute illness. The risk of lactic acidosis in metformin is 100 times lower compared to fenformin, and usually it is because the contraindication that I discussed were overlooked. Actually, the term metformin associated lactic acidosis has been it is an overhyped term. If you carefully look at contraindication and avoid metformin in these conditions, you generally don't end up having lactic acidosis with metformin. So these are the current recommendations for use of metformin based on eGFR. So if you have an eGFR of less than 30, there is no other option but to stop metformin, because beyond this GFR, your risk of lactic acidosis increases manifold. But between 30 and 45, you don't start any person on metformin. However, in a person using metformin, you use lower dose or you reduce by half. For example, if person is using 2 grams per day, you use about 1 gram per day. Between 45 and 60, you continue use but with the increased monitoring of renal functions. And if GFR is more than 60, there is no renal contraindication, you monitor renal functions annually. So optimal dose is 2 grams per day or 2000 milligrams per day, and it is approved as both monotherapy and a combination therapy. Coming on to alpha glucosidase inhibitors, these include agents like acarbose, miglitol and voclibose. These act by inhibiting alpha glucosidase at the small intestine brush border. And with various agents, obviously these agents act locally, so intestinal absorption is minimal with acarbose and voclibose. However, it is significant with miglitol. In clinical practice, we most commonly use acarbose or voclibose, which we give with the first bite of the meal in order to delay the carbohydrate absorption. So you have you start with one meal and then you add it at other meals. Generally, you start with the meal which is causing the highest postprandial glycemic excursion. So these agents, they have modest glycemic efficacy, and HbA1c lowering effect is between 0.5 to 1%. Obviously, these agents are less effective compared to sulfonylurea and metformin, and their maximum effect, because they delay the carbohydrate absorption, is maximum effect is on the postprandial blood sugar. What is important to note is that these agents by themselves, they don't cause hypoglycemia, but if they are used in combination with other agent which may have potential to cause hypoglycemia, for example sulfonylurea, the risk of hypo may increase. Important thing to note here is that if a person is on alpha glucosidase inhibitors and develops hypoglycemia, the person should be treated with only glucose solution, because any complex carbohydrate for treatment may be inadequate, since there could be blockage of alpha glucosidase enzyme. So such a person, if develops hypoglycemia, treatment should be plain glucose solution. No weight gain, postprandial hyperglycemia comes down. However, the adverse effects are important, which include effects like flatulence, diarrhea, And these agents are really used as monotherapy. We mainly use these agents in persons who are showing predominant postprandial hyperglycemia. Coming on to miglitinides, which are similar in which are in a way similar to sulfonylureas. They act by inhibiting ATP regulated potassium channel, but via a different binding site on beta cells of pancreas. These are short acting and they require multiple dosing. They cause effective postprandial control. However, these agents are unlike sulfonylureas, these agents have mainly their effect on postprandial glucose, as and a proportion of effect on fasting glucose is much lower. And these can in fact be used as a monotherapy in patients with highly erratic meal timings. Those in whom meal timings are not regular, where you won't like to use sulfonylureas, here you can use miglitine analogs. And these are less effective for fasting hyperglycemia because their duration of action is much lower. So you have different agents. What is important is that repaglinide can be used in patients with renal dysfunction as well. So adverse effects will be common. It could, as with sulfonylureas, you could have hypoglycemia and weight gain. HbA1c reduction can vary between 0.5 to 2%, and duration of action with repaglinide is up to 5 to 8 hours, while nitiglinide is even shorter acting. The duration of action is less than 4 hours. So problem with these agents is you require frequent dosing schedule. You require to give these agents before each meal, and these agents have been approved as monotherapy and also as combination with metformin. Coming on to thiazolidinediones, these are pharmacological agents for PPAR gamma or peroxisome proliferator activated receptor, and their most prominent effect is to increase peripheral glucose utilization. As they act at the level of insulin resistance, they tend to improve insulin sensitivity at the level of adipose tissue. They are also known to decrease hepatic glucose output at higher doses, and they improve adipocyte differentiation or increase adipocyte differentiation. And both rosiglitazone and pioglitazone were equally effective. However, rosiglitazone was withdrawn after concerns raised in terms of CV safety following an analysis in 2008. Coming on to adverse effects, with thiazolidinediones, weight gain can be more or equal to that with sulfonylureas. It is mainly at peripheral subcutaneous sites. You could have edema, you could have increased subcutaneous fat, and edema is more if it is given with insulin, and we prefer to not use thiazolidinediones with insulin. They could also cause anemia in long term, and an increased risk of fractures has also been seen. These have been approved by FDA for monotherapy, combination with metformin, sulfonylurea or insulin. Obviously, it is only pioglitazone which is approved for treatment. With rosiglitazone, as I have discussed, there were recent issues. It was found to be associated with CHF and higher CV mortality, and it has no longer been approved for use in our country. Concern about an association between pioglitazone and bladder cancer has been raised, mainly based on retrospective analysis. The drug was banned for some period of time, and now it has been reintroduced with limited prescription advisory. Newer agents, you have agents based on GLP-1, which GLP-1 is known to stimulate pancreatic insulin secretion and suppress glucagon. However, it has very short T half, so you need to use an agent which is like GLP-1 but with increased half-life, so that you don't need repeated administration. So one agent is DPP-4 inhibitors or dipeptidyl peptidase 4 inhibitors, which inhibit the degradation of GLP-1, or second agents are GLP-1 analogs, which are long-acting forms of analogs of GLP-1. So you have exenatide, weekly exenatide and liraglutide in this group. So this figure shows the incretin effect. So you have insulin levels following a glucose load. So these are insulin levels following an IV glucose load, and these are insulin levels following an oral glucose load. So you could see that there is a clear higher insulin secretion in terms of an oral glucose load, and this difference is because of incretin hormone secreted from GI tract, which go on to stimulate pancreatic beta cells. So this incretin effect, which is clearly demonstrated here, is blunted to a large extent in persons with type 2 diabetes, and that has been discussed as one of the pathophysiological factors in type 2 diabetes. So you want to target this diminished incretin effect by using hormones which are known to cause incretin effect. So So you have gliptins which will inhibit the degradation of incretin GLP-1, and we have different gliptins which are available, for example sitagliptin, vildagliptin, sexagliptin, linagliptin, teneligliptin. And reduction in HbA1c, it varies from between 0.5 to 0.8 to 1% across various studies. Important thing is that these are associated with weight neutrality or weight loss rarely. Mainly these agents are known to be weight neutral, and these agents have been shown to have either no or very less potential to cause hypoglycemia. Exenatide is a GLP-1 analog which is obtained from saliva of a lizard, that is Gila monster. It is resistant to degradation by DPP-4 enzyme with a plasma T-half of about 26 minutes after subcutaneous injection. Its doses is 5 to 10 micrograms and is required to be administered twice a day up to 60 minutes before each meal. These agents could have nausea and vomiting because they tend to delay the gastric emptying, or this could also be due to their central effects. You have other variants of GLP-1 analog, for example liraglutide, which can be administered varying from once in a day, which can be administered once in a day, and then you have dulaglutide, which is a weekly administered GLP-1 analog. So liraglutide, the half-life is around 15 hours, which allows once a daily injection. So dose you could once begin from 0.6 milligrams per day and could be increased to up to 1.8 milligrams per day. Semaglutide is a weekly variant of liraglutide which is in development. Coming on to SGLT2 inhibitors, we know sodium glucose co-transporters are located at two sites. SGLT1 is located in intestine, but some is also located in kidney. SGLT2 is almost exclusively located in kidney. SGLT1 has a role of dietary glucose absorption and renal glucose absorption, especially in the proximal convoluted tubule. SGLT2 has main role of renal glucose reabsorption. So if we see the S1 and S2 segments of proximal tubule, you have SGLT2 which is working. However, in the S3 segment of proximal tubule, you have some contribution of SGLT1 as well. So you have about 180 grams of glucose which is filtered daily, of which 90% is reabsorbed by SGLT2 and 10% is reabsorbed by SGLT1. SGLT2 inhibitors, what they will cause is they will inhibit this glucose resorption by sodium glucose link transporter 2, and thereby causing glucosuria. You could have difference in selectivity for SGLT2 versus SGLT1. So there could be certain agents which could be highly SGLT2 selective like empagliflozin, and there could be agents which could be relatively non-selective like canagliflozin. So again, the risk of hypoglycemia is not increased. They cause osmotic diuresis because when you have glucosuria, glucose will take away along with it some amount of water, which will also and some amount of sodium. So this can also cause natriuresis, and it can also cause decrease in blood pressure, can contribute because glucose loss will contribute to loss of calories. There could be weight loss. However, glucose is a potent culture medium, and it has been seen that patients using these drugs are at increased risk for urinary tract infection and mycotic genital tract infections. Other concerns could be decreased BMD and risk of carcinogenesis, which has not been defined. So we have different agents. For example, for dapagliflozin, the starting dose is 5 milligrams. For canagliflozin, starting dose is 100 milligrams, and for empagliflozin, the starting dose is 10 milligrams. And there are different caveats for use in patients with renal insufficiency, because these drugs are primarily dependent on glomerular filtration of glucose. So if glucose filtration is affected, these drugs are likely to be ineffective. So for most agents, an eGFR of less than 45 is considered as an advisory for not using the agents. Coming on to recommendations in terms of oral anti-hyperglycemic therapy, metformin is the best first line agent, at least in obese patients, and however its anti-hyperglycemic effect is not dependent upon weight. So in most patients with diabetes, the first line monotherapy is metformin, unless it is not tolerated or there is a contraindication. Insulin secretagogues, for example sulfonylureas, these are being used. However, these are being used, their use has come down with advent of safer agents like DPP-4 inhibitors. However, in patients who have financial constraints, and who could follow a strict dietary regimen, which is regular dietary schedule. These are very good agents, could be used as a first line monotherapy in combination with metformin. Non-acute secretagogues especially useful in patients who have irregular meal schedules because they have shorter duration of action. Gliptins, these are mainly used as a second line agents along with SGLT2 inhibitors, as second or third line agents after metformin and sulfonylurea in resource constrained settings. For thiazolidinediones, these are only being used in very specific cases. The future for them is not very clear. We know that diabetes is associated with progressive beta cell failure, and this slide shows what that about beta cell function is already affected when person is diagnosed with diabetes, and progressively it decreases. So by 8 to 10 years after diagnosis of diabetes, beta cell reserve is minimal, and most persons with progressive beta cell failure and long standing diabetes, they may not be able to have that good a glycemic control after acute metabolic decompensations like DKA, hyperosmolar coma, or diabetic women who are planning for pregnancy, where you require a much more stringent glycemic control. And also in pregnancy, it is insulin which has been shown to be most the safest. Rationale for oral agents and insulin in type 2 diabetes. So at times we try to use insulin in combination with the oral agents because it simplifies insulin regimen, it improves glycemic control, it improves compliance, it is convenient for patients at times, and it lowers doses of insulin that is being administered. Coming on to different kinds of insulin in type 2 diabetes, we could use a single intermediate acting insulin at a bedtime. You could use an intermediate or long acting insulin at bedtime. For example, you could use a glargine at bedtime, you could use a etimir at bedtime, you could use an NPH insulin at bedtime. You could use a long acting insulin analog, that is a glargine insulin once a day, which could be used most often at bedtime, and then you could use a twice daily premixed insulin, which is having a combination of both regular and an NPH insulin in a fixed dose combination. Most common used formulation is a 30:70 formulation, which contain 30 proportion of a regular insulin and 70 proportion of a NPH insulin. So this is showing anti-hyperglycemic therapy recommendations which were published in Diabetes Care in 2015, and you could see that you begin with metformin, and then you could consider adding sulfonylurea, thiazolidinediones, DPP4 inhibitors, SGLT2 inhibitors, GLP-1 agonist, or a basal insulin. However, it is important to remember that in patients with initial starting A1C of more than 8.5 to 9%, it is always better to start with two drug therapy. So you start with dual therapy right at its onset. Subsequently, if HbA1c target are not met, then you could switch to triple therapy, which could include addition of one of these various agents, and you have to consider various factors like efficacy, risk of hypoglycemia, weight, side effect, and cost before deciding therapy for a given patient. So there is no one therapy that can be ideal for all patients, so you have to individualize and decide the that possible treatment option in each patient. So as I have mentioned, if you have A1C, starting A1C of more than or equal to 9%, you go to a dual therapy. If you have metformin intolerance or contraindication, you directly jump to sulfonylurea as your first line therapy. In patients with uncontrolled hyperglycemia with catabolic features, with microvascular complications, or those who are planned for any surgery, you want to switch to a combination injectable therapy. Right. So coming on to type 1 diabetes, which is a slightly different form of diabetes, where you the basic pathophysiology is autoimmune beta cell destruction, and so you require, these persons have absolute insulin deficiency, and they require insulin right from the onset. So this is a picture showing the discovery of insulin by Banting and Best, and this shows how a patient with type 1 diabetes looked before insulin was he was started on insulin injection, that is before pre-discovery era, and how the person, the catabolic features have reversed following starting the therapy with insulin. So treatment of type 1 diabetes, only treatment is with insulin, and as with type 2 diabetes, it has been shown that tight glucose control results in improvement cardiovascular complication, and this was shown in study which was called as diabetes control and complications trial, which in 1993. And as you could see here that in these Kaplan-Meier analysis, you could see that in the intensive group versus conventional group, you could see that there is a reduction in various endpoints, mainly microvascular complications. If we see when we start treatment with insulin in persons with type 1 diabetes, we try to mimic the physiological plasma insulin profile. So you have the insulin levels which rise with each meal and then they go down, and then you have some basal insulin secretion. So in our body we have two different kinds of insulin secretion. One is a basal insulin secretion, which is present at all times in order to suppress hepatic glucose output, and then you have a prandial insulin secretion, which is meant for glucose disposal with each meal. So when we try to mimic this physiological regimen in persons with type 1 diabetes, we need to give a basal insulin which could provide a 24-hour coverage, and we want to add prandial shots before each shot, before each dose, before each meal. So you have a basal insulin which needs to be administered either once or twice in a day, and then you have short acting prandial insulin which needs to be administered thrice in a day. So coming on to pharmacokinetics of available insulin, we have regular or short acting insulin, which is an insulin which is prepared by recombinant recombinant DNA technology these days, and which is not associated with various allergic reactions or lipoatrophy reactions which were seen previously with bovine or porcine insulin. So the regular insulin is in form of insulin zinc crystals which are dissolved in a clear fluid, and after subcutaneous injection it tends to associate and form a dimer, and 3 dimers then subsequently forms the hexamer. So it exists in the hexamer form. However, it is only the monomeric and dimeric form which is absorbed and it is active, and you have a delay of 30 minutes before action of regular insulin. So in a patient using regular insulin, you need to inject the regular insulin 30 minutes before the meal is actually taken. So this is showing meal related insulin therapy in today's world when you are using when you are using subcutaneous human insulin plus NPH in a fixed dose combination. So you're trying to mimic the peaks. However, you can see these peaks are different from the physiological insulin profile. However, you are trying to mimic these peaks. So what is important to consider here is that because we cannot exactly match the physiology, so you could have mismatch between meal related increase in blood glucose and insulin. Blood glucose could remain high 1 to 2 hours after meal if postprandial action is inadequate, and you could have chance of low blood glucose 4 to 5 hours after injection, because you still have a persistent insulin effect when you would expect blood glucose to have already gone down. So you could have postprandial hyperglycemia and you could have delayed hypoglycemia with these kinds of insulin, that is regular insulin. If you have short acting analogs which have more pronounced postprandial action and less pronounced delayed action, you could decrease the tendency for postprandial hyperglycemia and delayed hypoglycemia. And how do you do that? So these short acting analogs, they have decreased tendency to self-associated therapeutic concentration, that they don't form dimers or hexamers and they are directly absorbed in their monomeric form. So you don't need to wait for these insulin before meal. So you can inject these insulin 5 to 10 minutes before meal, immediately before meal, or even after meal. So these could be useful in small kids where you don't know what quantity of meal that kid is going to consume. And these insulin are also then shown to have shorter duration of action, focusing more on postprandial action. So you have these insulin which are created by changes in the amino acid constitution of the original insulin molecule. So you have insulin lispro, insulin aspart, and insulin glulicin, which are available as your short acting insulin analogs. And these insulin, they have much more physiological action, so they try to mimic the physiological peaks, and the peak also comes down with time. So you tend to have better control of postprandial glucose or postprandial hyperglycemia, and you also tend to avoid delayed hypoglycemias. So short-acting analogs, the advantages are, as I have discussed, there will be flexibility of injection. You could shoot and eat. That means you inject and then you can immediately eat, and rather not waiting for about half an hour. You tend to have lower 1 hour and 2 hour post-meal blood glucose. So in a person where postprandial hyperglycemia is bothersome, you could consider using short-acting analogs. And with optimal basal insulin, they have been shown to have reduced HbA1c. However, overall glycemic efficacy does not vary between short-acting analogs and regular insulin. You tend to have less frequent hypoglycemia because the delayed action is averted. And if you have lesser hypoglycemias, you tend to have better awareness and better counter regulation to repeated episodes of hypoglycemia. Coming on to intermediate acting insulin, you have these insulin have been shown to have longer delay in their onset, and they have a longer duration of action. In clinical setting, these could be used with short acting insulin either as a fixed dose combination, or these are used separately. So most commonly used intermediate acting insulin is neutral protamine hedgehog insulin, which is crystalline suspension of recombinant human insulin with protamine and zinc, which tends to delay the absorption of insulin, and which tends to keep it in a multi-hexamer form. Then you have long-acting insulin analogs where you have insulin like insulin glargine, insulin detamir, and insulin degludec. So this is the structure of insulin glargine, where you have asparagine, which has been replaced by glycine in the A chain, and you have two arginine molecules have been added to the C end of insulin B chain. And what does this do is this causes a change in isoelectric point towards neutrality. So resultant insulin is solubilized in acidic solution and precipitates as a microcrystals after injections. Similarly, for detamir, you have C14 fatty acid chain, which helps to bind to albumin and increases its half-life. And for insulin degludec, you have fatty acid acylation, and you have addition of a glutamate spacer. So this diagram shows how there is a slow release following injection, and how this slow diffusion of zinc leads to release of monomers, and monomers slowly enter circulation, providing a long action and a peakless effect. So if we see, for regular insulin, onset is at 30 minutes, peak is at 2 to 4 hours, and duration of action is a little long, which is around 6 to 8 hours. For analogs, it varies, the onset varies between 5 to 15 minutes, peak occurs at about 1 to 2 hours, and duration of action is lower, that's around 3 to 4 hours. For NPH insulin, you have onset at about 1 to 3 hours, peak is there is a defined peak at 6 to 8 hours, and then you have duration of action about 12 to 16 hours. With glargine, you have a broad peak with onset of action at about 6 hours and a duration of action around 24 hours. However, with degludec, your onset starts at around 30 to 90 minutes, and there is no defined peak, or this is a peakless form of insulin with duration of action lasting more than 24 hours. So approach to treatment in person with type 1 diabetes, you tend to try to have strict metabolic control. For strict metabolic control, you need to use 3 subcutaneous pre-meal regular insulin and additional bedtime intermediate or long-acting insulin. For example, you give regular insulin before breakfast, before lunch, and before dinner, and a shot of NPH insulin or a glargine at bedtime. And you could use either syringe or pen devices. Pen devices are generally more comfortable for the patient. In insulin pumps, you could have these whatever insulin regimens we have discussed, these are subcutaneous insulin regimen, and these are intermittent. So you are injecting subcutaneous insulin intermittently. So you could have continuous subcutaneous insulin delivery using insulin pumps, where you could use regular insulin, but preferably you use insulin analogs in insulin pumps. However, the therapy this is indicated in persons with significant glycemic variability who want to have more flexibility in their lifestyle. However, insulin pumps are associated with significantly increased cost of therapy, and there you have a short-acting insulin analog which provides both basal control, and you have an option of administering pre-meal boluses. So coming on to complications of insulin therapy, insulin could be associated with increased risk for hypoglycemia, weight gain. During initial period when you use insulin therapy, there could be rapid glycemic control, and that could be associated with worsening of retinopathy. However, in long term, good glycemic control has been shown to improve retinopathy, and so this should not deter us from using insulin in persons with poor glycemic control. Insulin allergy, as I have discussed, because we are not using bovine or porcine insulin, insulin allergy is rare in these days, and insulin site hypertrophy can occur, especially with use of the same needles. When the needles get blunt, you could have insulin site hypertrophy, and this could cause variability in terms of glucose control. Again, it is important that the patients, especially those who are on multiple shots of insulin, take 6 meals, which include 3 large and 3 small meals per day. The diet requirement is calculated as per their ideal body weight. You emphasize the use of low glycemic index foods, especially when they feel hungry. They should not miss meals, and when they have they have party time, or when they tend to have meals other than what is prescribed, they should be provided a flexibility in terms of increasing the dose of soluble insulin, calculating the insulin carbohydrate ratio, and accordingly changing their doses of insulin. When they travel, insulin should always be kept in handbag, and extra supplies of insulin should be kept. Insulin should be stored in a cool place, that is in a refrigerator, in an earthen pot. However, insulin should never be frozen. Coming on to HbA1c monitoring, it should be in persons with type 1 diabetes. It should be in form of HbA1c, which should be performed at least 4 times in a year. That is every 3 monthly. You should see their home blood glucose log. You should monitor height and weight in children, because you want to see whether you want to see if there is any effect of chronic systemic illness on the person's stature. Fundus should be done, especially after puberty. You should look for proteinuria, neuropathy, diabetic foot infections, and lipids. So there should be an annual evaluation for all of these things, and the evaluation for various complications in type 1 diabetes, usually it is said that it should begin after 5 years of duration of diabetes and after a person has entered puberty. Coming on pumps, as I have already introduced it in little detail earlier. So insulin pump is a continuous subcutaneous insulin infusion, which uses a portable pump which is connected to an indwelling subcutaneous catheter to deliver short-acting insulin, which in most cases is short-acting insulin analogs like insulin Aspart and insulin Lispro. However, regular insulin can also be used. Insulin pumps have been shown to have significant advantages over multiple daily injections in terms of reduction of glycemic variability, reduction in terms of hypoglycemia, and subsequently reduction in weight gain. These are extreme for routine practice, but may be especially useful in special circumstances. For example, persons with extreme glycemic variability, recurrent hypoglycemia, hypoglycemic unawareness, recurrent episodes of decay. Hypoglycemia is in a person with diabetes. Hypoglycemia is defined as a capillary glucose of less than 70 milligrams percentage. However, in person without diabetes, hypoglycemia is defined according to Whipple's triad, that is, you need to have a low plasma glucose of about less than 55 milligram percent. You should have symptoms of hypoglycemia, and these symptoms should get reverted once you give glucose solution. Glucose threshold to hyposymptoms and physiological response vary widely across various persons, and once you try to achieve near normal glycemia, you invariably increase the risk for hypoglycemia. Conventional risk factors for hypoglycemia include excessive dose of insulin or oral hypoglycemic agents, ill-timed or wrong administration of insulin. If you have missed overnight, you have an overnight fast or missed meal or snack, excessive exercise, increased insulin sensitivity, for example in the middle of night, reduced endogenous glucose production due to alcohol, or reduced insulin clearance due to a renal failure. Clinical manifestations, these could vary. Most initial manifestations are autonomic, and then you have neuroglycopenic at severe, which begins at blood glucose levels of less than 45 to 50 milligram percentage. However, in persons with recurrent hypoglycemias, you could have blunting of autonomic symptoms, and they could directly land up with neuroglycopenic symptoms. So autonomic symptoms could include adrenergic or cholinergic symptoms. Adrenergic symptoms include symptoms like palpitation, tremors, and anxiety. Cholinergic symptoms include those like sweating, hunger, or paresthesias. In terms of neuroglycopenic symptoms are caused by decreased glucose delivery to brain, so you could have behavior changes, confusion, fatigue, and seizures. Treatment, you have oral treatment with glucose containing fluids. Reasonable initial dose is 20 grams or 15 to 20 grams of glucose, or 3 or 4 teaspoonful of glucose. IV glucose 50% solution followed by a constant infusion of 5 to 10% dextrose can be administered in persons with hypoglycemia and unconsciousness. Glucagon can also be administered, which helps to mobilize glucose from the liver stores. OHAs induce hypoglycemia or sulfonylurea induce hypoglycemia because these tend to be prolonged. Person must be hospitalized, and only one off treatment, you could have recurrence of hypoglycemia. So these persons should be hospitalized and observed for about 24 to 48 hours till they get hypo-free. Coming on to diabetic ketoacidosis, the definition of diabetic ketoacidosis includes D, K and A. So you should have diabetes, that is hyperglycemia, glucose of more than 250 milligram percentage. Usually we see glucose of around 500 to 800 milligram percentage. You should have K, stands for ketones. So you could have ketones both in urine and serum. The ketones that are increased include acetoacetate, acetone and beta hydroxybutyrate, and these cause a fruity smell which you may not encounter commonly. However, in persons with severe decay, you could get a fruity smell on clinical examination, and you need to have acidosis, which is a high anion gap sort of metabolic acidosis. So targets for treatment in these patients are that you correct acidosis, hyperglycemia, electrolytes, and also look at the precipitating factor. And we do that with the use of IV fluids. You tend to infuse isotonic fluids to correct hypotension, to correct dehydration, to improve insulin action. Then you administer insulin, which is in form of intravenous injection of regular insulin. At the same time, you take care that with insulin therapy, there is increased risk of potassium, transcellular shift of potassium. So persons tend to have increased risk for hypokalemia. So you give potassium supplements and also monitor potassium frequently, and look at the precipitating factor, treat it, and also educate patient in order to prevent a repeat episode of decay. So thank you so much, and I'll be happy to take any questions.